So benzodiazepines, the antidote here is flumazenil or romazicon. Think about this as being the Narcan, but for benzodiazepines. Why do we not use it? Why do we not carry it? Because if you end up giving the medication, you may end up actually causing some seizure activity to develop, and we don't want that to happen. So it's an untoward effect, and really the side effects of the medication can be worse than what the overdose is. So with your benzodiazepines, if you recall, really the thing that we need to be worrying about is really airway and respiratory efforts. So if we can make sure that their airway is protected and that they're able to ventilate appropriately, there's really no reason to administer the flumazenil or romazicon, because the benzodiazepine will eventually wear off. With beta blockers, we can think about glucagon, and that's 3 milligrams IV push. That's kind of what you start at as far as your beta blockers. Calcium channel blockers, if you have somebody that has taken a calcium channel blocker, they're blocking the ability for the calcium channels to do what they're supposed to do. The antidote here is going to be calcium, and I know that now calcium chloride, calcium gluconate are being carried. So if you have a calcium channel blocker overdose, calcium would be the antidote, or what you should be thinking about giving, and it is 1 gram IV push. For cyanide poisoning, hydroxycobalamin is the new. This is your treatment if somebody has been pulled from a fire and you think that they have any type of cyanide poisoning. The old system was amyl nitrate, sodium nitrite, and sodium thiosulfate. We've gotten away from that as much as we can, because if they are not cyanide poisoned, then by giving that 3-drug combination, we basically prevented them from being able to carry oxygen. By giving hydroxycobalamin, it's vitamin B12. And if any of you are drinking an energy drink, I say this every time I do this talk, look at the back of your energy drink, your Monster or whatever it is that you're drinking, and you will find that it contains cyanocobalamin, which is again, vitamin B12. So in that situation, if they are cyanide poisoned, we have saved their life. If they're not cyanide poisoned, then we have just given them a really, really hefty dose of vitamin B12, and it won't cause any long-term effects. With your opioids, we're thinking Narcan. Everyone's familiar with that at this point. Tricyclic antidepressants. So the two that are really big are your amitriptyline and Elavil. And from a testing procedure, this is a national registry test question. It is a national registry hands-on scenario. If you're doing your hands-on and you're integrated out of hospital patient encounter, you're going to be probably presented with an amitriptyline or an Elavil overdose. And the antidote here is sodium bicarbonate. And we give 1 amp or 50 milliequivalents. It's 1 milliequivalent per kilo. That is the standard dose of sodium bicarbonate across the board. And how will we know to do that? It's when your QRS starts to widen out. So if they give you a situation that says you have a patient that has a tricyclic antidepressant overdose, or they'll use one of these by name, amitriptyline or Elavil.
Here you go, miss.
And you notice that the QRS is starting to widen out, what would be your appropriate treatment? The answer is the administration of sodium bicarbonate. For dystonia or dystonic reactions, if it has been caused by Haldol or Phenergan, the treatment here is 25 to 50 milligrams of Benadryl or diphenhydramine. Specific ingested poisons, we talk about acids and alkalis and which one is worse. So really the alkali is the one that is worse. So the reason for that, acids, excuse me, with acid burns, you end up getting what is called a coagulative necrosis. So you start to actually kind of form a skin scar, if you will, and it prevents further penetration of whatever the acid is down into deeper tissue. In your alkali burns, you don't get a coagulative necrosis, you get a liquefactive necrosis. And what happens with your liquefactive necrosis is you don't get that scarring formation. So whatever the alkali is able to penetrate deeper into the skin, and it causes a more deeper, more severe burn. Dilution, you can either do that with milk or water, 200 to 300 mLs. Most of us are probably going to use water because it's in abundance. Laundry detergent pods, there were 10,000 exposures in a 10-month period in 2017. Interestingly enough, my wife happens to work for one of the big consumer products companies in Cincinnati, and her boss actually had to testify in front of Congress because of this situation. And they kind of got a bad rap, but the reality was it wasn't necessarily the brand name. Certainly they may have been responsible for some of them, but you know, there's knockoffs and people would eat them, and then the kids would eat them because they look like candy, and you probably remember that many years ago. But it would always get referred back to what the brand name was, right? So what we're going to do in these situations and with all poisonings, the solution to pollution is dilution. So wash off the skin in copious amounts of irrigation. If it's a hydrocarbon poisoning, there's really not a pre-hospital treatment that is available. With methanol, we want to make sure that we don't give any type of activated charcoal. In fact, in today's world, we should not be even carrying it. A couple years back, K-beams did require it, and you actually had to have a waiver to not carry it. So I would submit a waiver every year saying we do not want to carry it. And then ultimately K-beams caught on and they said, oh, okay, well, nobody should be carrying it. So now you're not allowed to carry it. And if you want to, you have to have a waiver in order to carry it. Poisonings kind of continued here. Ethylene glycol, antifreeze or windshield fluid, thiamine can be administered to degrade the glycolic acid to what are non-toxic metabolites. So if you have thiamine, which is again a vitamin, you guys probably learned when you were talking about Korsakoffs and Wernicke's in paramedic school, but it basically breaks down the glycolic acid into things that your body is able to utilize and metabolize, and it doesn't really cause a lot of problems. They may end up having seizure activity, and we can give benzodiazepines for that. Isopropanol, no pre-hospital treatment is known at this time. Metals, there are different metals out there. Iron and lead are the most common. Not a lot that we're going to be able to do for that. Mercury, if it is a mercury exposure, then dialysis is the treatment, in which case we need to have rapid transport. You can see again your tricyclic antidepressants, severe hypotension and cardiac arrhythmias, the wide QRS complexes, and the antidote, once again, the sodium bicarb. And that is on there 2 different times because it is very, very important that you guys end up getting that if you are to happen to see that in testing. And certainly if you see it in reality, we should be thinking about administration of sodium bicarb. Your cholinergics, you guys are probably more familiar with your anticholinergics. Your anticholinergic, the one that would come to mind most commonly is going to be atropine. That's your anticholinergic. And if you think about why we would give an anticholinergic, it's for this, right? Cholinergic poisonings. And you guys probably remember sludge or sludgum. There's different things out there, and we have both muscarinic and nicotinic effects. But your pesticides, your organophosphates, and your carbamates will cause cholinergic overdose. Your nerve agents like sarin and soman are another one that will do that, in which case you can see there the salivation, lacrimation, urination, defecation, GI upset, and then emesis. So everything starts to basically escape the body. So how do we treat it? We give an anticholinergic to help dry them up. And that is why if we have a patient that we think has been exposed to an organophosphate, the drug of choice is going to end up being atropine, not necessarily your 1 milligram, but many, many, many milligrams, like a couple 100 milligrams is what you're going to need to give. So the reality is you don't carry enough. You're going to end up having to contact the hospital, and they're going to have to pull all the atropine that they can so that you can hopefully reverse the effects of your cholinergic overdose. Just interestingly enough, one other medication, when I said anticholinergic, maybe some of you were thinking about atropine. There is another anticholinergic that we carry. And that medication is the ipratropium. So when we're talking about Duoneb, we give them albuterol and ipratropium. And if you think about why we would do that, your albuterol is your beta-2 agonist. It's going to open the airway and allow for better gas or better ability for the patient to get gas in and out. But why would we give the ipratropium? Well, remember, with ipratropium, it is an anticholinergic medication, so it is going to dry secretions. And if you think about it, when we're talking about a patient that is a chronic bronchitis patient, those goblet cells have an increase in mucus production. And because of that, we're getting a lot of phlegm and we're getting a lot of mucus, and we're trying to dry that up as best we can. So how would you give that? You would obviously give it as a duoneb with both your albuterol and ipratropium. Cholinergic treatment here, your ABCs, decontaminate the patient. Think about atropine, 1 milligram IV push every 3 to 5 minutes. And as I said, you're going to have to keep giving it over and over and over. And then the other medication with this duodote is a medication called pralidoxine. And this actually comes as a duodote. So there are 2 different medications. You have your atropine here and you have your pralidoxine here, and it's affectionately known as 2-PAM. So you all are probably familiar with that. And in reality, you probably even have some available from many years ago when it was delivered from emergency management. Anticholinergics, antihistamines, antipsychotics, tricyclic antidepressants, and then there's plants out there. We're not going to cover all these, but it goes back to the old saying, red as a beet, blind as a bat, mad as a hatter. So they're trying to paint a picture of how this patient will look. So they're going to have tachycardia, dry flushed skin, dilated pupils, and facial flushing. The management here is airway, breathing, and circulation, and then benzodiazepine administration. Hallucinogens, LSD, PCP, and mushrooms, really the thing here is making sure that we are safe. These patients, and especially if we start talking about synthetic marijuana, these patients can become very violent. Make sure that you're protecting yourself and your crew. For the most part, it's more of a scene safety thing for us, and then transporting the patient in. Opioids, I'm not going to cover. You all are probably as versed as I am with dealing with opioids. Basically, it's a respiratory thing, so titrate the effect of your naloxone or Narcan so that you can get the patient at least breathing. You don't necessarily have to wake them up. Your sympathomimetics, so big words, sympathetic is what we're talking about here. So your sympathetic nervous system, and we are mimicking it. That's all we're talking about. That's what your sympathomimetics are, your CNS stimulants. So amphetamines, whether that be just an amphetamine or if it is something like methamphetamine, cocaine, bath salts, caffeine, nicotine, anything that is going to kind of amp that patient up. So they're going to have an increased blood pressure, tachycardia, dilated pupils, altered mental status, paranoia, etc. If it is cocaine overdose induced, one thing, and this may change with your protocol, but it's always been benzodiazepine administration, and really it's always been Valium, but follow your protocol if you ever have a patient that is overdosed on cocaine. Alcohol use disorder, we talked about thiamine a few minutes ago. For the Wernicke's and Korsakoffs, remember that the Korsakoff psychosis is usually considered to be irreversible. So once they have it, it's probably not going to go away. With Wernicke's encephalopathy, that will go away as long as they have proper treatment. But these are both going to be related to alcohol use disorder. I was at my NP job yesterday talking to a patient of mine whose brother is suffering from alcohol use disorder. I'll tell you, alcohol use disorder is very, very difficult to overcome. And the evidence that is out there working from an addiction medicine perspective and in family medicine, the relapse rates and the ability to overcome alcohol is actually harder statistically than it is with your opioids and other medications. So if people have alcohol use disorder, they need support. They need people that can kind of help them through that process. It is a very, very difficult thing to overcome. So nutritional deficiencies, thiamine, most of us don't carry thiamine, but in the hospital, the nutrients and the vitamins and things are what they're going to end up needing. So hypoglycemia is something else that we should be thinking about here. Administer your thiamine with glucose. Your thiamine's 100 milligrams slow IV push, rapid onset, and it may cause hypotension and some other untoward effects as far as like anxiety, diaphoresis, etc. But for the most part, it's a pretty benign medication. It really is just a vitamin that you're giving them. They are prone to other issues. So the falls, right? They have thin blood, so if they fall and they strike their head, they're at a higher risk for having subdural hematoma. There's a lot that goes on with alcohol use disorder. And patients with cirrhosis could also have esophageal varices. Remember that if the liver is scarred and it is not draining appropriately, then things start to back up, and the liver veins will back up into the esophagus, and that's where this esophageal varices comes from, and that becomes an airway concern. We have to really pay attention to that. We talked about dystonia with Haldol or Phenergan. We're going to give 25 to 50 milligrams of Benadryl or diphenhydramine. Other things that we can give Benadryl and epinephrine for are wasp and bees, or the other anaphylactic or allergic reaction situations. So anytime you have somebody that has an exposure to a wasp or a bee, try to get the stinger out if you can. Think about Benadryl and then give them epinephrine if it is appropriate to do so. And it shouldn't be because they have just a general allergic reaction to it. We're talking the patient is actually having symptoms of respiratory distress, their throat is closing off. Then think about giving them epinephrine. Obviously, the EpiPen is here, or you can just simply draw up Epi 1 to 1,000 and then administer that. Spiders, scorpions, and ticks. Ticks are really bad right now, so I will mention that. If you're outside in the woods, cutting grass, doing any of that kind of stuff, make sure that you are checking yourself for ticks, because ticks can lead to some pretty dire issue if patients are bitten by ticks and it goes unrecognized. I'm not going to go in too much to the spiders and scorpions, but just know that we do have both black widow, and we also have the brown recluse here in this area. If you're in the northern Kentucky or greater Cincinnati area, if you're watching from somewhere else, I'm not 100% sure where you're at and what you have there, but these things are pretty detrimental. I've told this before, probably in this lecture before, but many years ago, I had a lady that we got contacted for she was ill following a spider bite 2 weeks prior. And to be honest, like the whole way to the scene, I'm kind of grumpy and, it's been 2 weeks. Why are they calling us? And when we got there, she had actually been bitten by a brown recluse 2 weeks prior and was still like deathly ill. Like legitimately, I thought the lady was going to die. And after talking to her, I'm like, how do you know that you were bitten by a brown recluse? She said, because we killed the spider and took it to the hospital. And sure enough, we got to the hospital, and I actually talked to the staff there and said, hey, look her up and see when she was here and what was said. And for those of you that remember Dr. Vest, Joni Vest was an ER physician. She actually had seen her and documented in her chart that the patient did in fact bring the brown recluse in, and Dr. Vest had verified that it was a brown recluse and that she had been bitten by that. So don't underestimate them. Your black widows have neurotoxic effects, and then your brown recluse can have local tissue necrosis, so the tissue around the bite site will start to die off, but it can actually give them symptomatic or systemic symptoms and make them very, very ill. All right, so the brown recluse here, you can kind of see, we always talk about kind of marking the area just so that you know if that area is getting bigger or not. But beyond that, there's really not a whole lot that we're able to do for this. You don't need to do anything heroic or try to put ice on it or anything like that. For the most part, just kind of let it do its thing, transport in, and let the hospital take care of it. As far as scorpions, the sculptured or black scorpion, it's really the only dangerous species to human in the United States. And it's found in the Southwest United States and in Mexico. And there's venom delivered by a stinger on the tail. I never really got into all this stuff. Waldo, if you guys remember Jeff Waldenmayer, some of you's probably had him, is a paramedic instructor. Jeff is very, very well versed in this, and he always studied the toxicology portion. He just was really into that. So he was always pretty fascinating to talk to about like your snake bites and scorpions, so on and so forth. But I just kind of go with the information that's been presented. So Rocky Mountain spotted fever, this is an infectious disease from rabbits and other small mammals via a tick bite. So I told you, make sure that you're checking yourself and your animals, those types of things, for ticks, because they do have not only the Rocky Mountain spotted fever, but they can also lead to Lyme disease, which will end up causing some cranial nerve palsies, lethargy, muscle pain, general malaise. Lyme disease actually is a pretty nasty thing. and it will carry a lot of very unfortunate effects for the patient long term. Tick paralysis is something that you should at least be familiar with because we do have ticks in the area. There is a neurotoxin that is released by salivary glands of the tick. So the patient will become restless and complain of paresthesia in the hands and feet. And paresthesia is like pins and needles, or the tingling. After about 48 hours, they end up with what is known as flaccid paralysis. And here's really the characteristic of this. It starts at the feet and works its way up. So if my feet don't work, and then it starts to move itself up the body, you're probably dealing with a patient that has a tick paralysis. And then eventually the respiratory system becomes depressed once it elevates up to that level from the feet, and that leads to death. For tick removal, if you do have a patient or you have a family member that has a tick, the real recommendation from the American Academy of Family Practice Providers is to grab the tick with tweezers and pull them out with steady pressure, and then clean the area with soap and water. Reptile bites, I'm just not going to get close enough to determine exactly what's going on. Snakes is one thing that I don't necessarily do, but you have pit vipers, and those are your rattlesnakes, cottonmouth, copperhead. They say that they have a vertical and an elliptical pupil and a triangular head. I prefer not to get close enough to be able to determine that. But it's something that at least be familiar with. The reptiles, and depending on the type of venom that it actually injects into the patient, you can have some of the things here. Hemolysis, remember those red blood cells start to break down. Intravascular coagulation, so you get all kinds of different coagulopathies where they're either clotting too much or not clotting at all. They can have a seizure activity, and then acute renal failure. Not a lot that we're able to do, kind of like the spider bites, airway, breathing, circulation, get IV access. Extremity, you want to immobilize it in a neutral position because we don't want to allow that toxin to just be releasing freely. So try to just get it neutralized as best you can and not move the extremity. But like the spider that we talked about, you don't necessarily need to use ice packs or put tourniquets on or anything like that. Coral snakes is another one that from a national registry perspective, they always talk about. So 2 members of coral snakes in the United States, the Arizona and the eastern coral snake. And there's a little rhyme here: red on yellow, kill a fellow, red on black, venom lack. And that is how you can kind of look at the snake and determine if it is venomous or not. So red on yellow, kill a fellow. You can see that this snake here has red and it touches yellow. So this would actually be a venomous snake. If this was red on black, so if the red touched the black without touching the yellow, then venom lack. It is the non-venomous species. And again, I don't necessarily want to get close enough to figure it out. So basically, at the end of the day, snakes and spiders, what you need to know is what kind you're dealing with, whether it's venomous or not. And then it's either going to have neurotoxic effects or it's going to have cardiotoxic effects. So it's either going to affect their neurological system or it's going to affect their cardiovascular system for the most part. Hazardous aquatic life, colintrates or jellyfish, fire coral, all of these basically are treated the same way, and we'll kind of talk about what that is. So signs and symptoms here, they're going to have nausea, vomiting, headache, abdominal pain. There's a lot that goes into the hazardous aquatic life. Really, the only thing that we're able to do is remove anything that we can see visibly. If they have a tentacle, a fragment that is attached or has penetrated the skin, try to remove it. Wash the area with vinegar is what the recommendation is, and then put it in hot water for as long as the pain persists. So the hot water thing, remember that these aquatic life, they are meant to be in a cool or cold water environment. So as soon as you put them in hot water, it really kind of breaks down what the intent of that poison is. So if you can put it in hot water, it will really neutralize the pain and it will quit working. And I have seen this happen firsthand. At the Newport Aquarium, it's been several years ago now, but we got called there for an envenomation. And I was like, okay, immediately thinking snake. And when we got there, it was actually one of the divers that had a stingray put a barb through his hand. And this guy was in really good shape. He was actually military and was there diving and was one of the volunteers. We ended up getting the paperwork, which was written by Dr. Otten, a toxicologist at university, told us what to do for the situation. And really, it was like, it's not really a long-term danger thing. It's more about pain management. So it said get hot water and put hot water on it. So we did. We got like a bucket of beers would come in. And we ended up taking the guy's hand and put it down in the hot water, and he immediately got pain relief from it. We started a line, gave him some pain medication, and then transported him over to University Hospital for them to deal with it. So the hot water will definitely help to neutralize the aquatic life and venomations. So they're all basically the same, and for those reasons, I'm going to continue on here. A lot of them here. So here's a stingray, 1,800 injuries per year. 2 inches to 14 feet. So they can be very, very large. They bury themselves in the bottom sand and sting to defend themselves. And actually, I've had an opportunity to go swimming with them. They're really actually very interesting creatures. You just don't want to get the barb to go through your hand or, in the case of Steve Irwin, in your heart. So the stinger is located on the dorsal aspect of the tail. And it's accidentally stepping on the animal, causing a sting to the foot or the leg. Venom will auto-inject into the wound, and the barb may break off in the wound. So in the situation that we had, it just got his hand as he was in the tank with the animal, but it didn't break off, and it really doesn't leave an envenomation. So it's not, it says venom, but it's really not a deadly kind of thing. It's more about just getting the neutralization by giving hot water, and then the pain will go away. No. So signs and symptoms here: localized, immediate, and intense pain, and it was for that individual. Localized edema, variable bleeding, and then tissue necrosis that can occur, and then systemic. So what's going to happen throughout the body depends on the animal and what is going on. So with the stingray, none of these things really, other than pain. But obviously with some of the other stings that you may end up having or envenomations, all of these things may be present as well. The management: airway, breathing, circulation, put them on a monitor, check their vital signs like we would normally do in all of our BLS patients. Irrigate the wound with normal saline or tap water. Remove the barb if it is visible in this situation here, immersed in hot water, and then give them analgesics. And that's exactly what we did. And in that situation, as I told you, that they're already pre-planned by Dr. Otten. He knows every animal and the species that are down there and what you should do in the event that you have an interaction or an account with one of them. So they have laminated cards, and we showed up. They handed us a laminated card. It was literally like, okay, give me a few seconds to read this. I read it. It was like neurotoxic effects, none. Cardiotoxic effects, none. Signs and symptoms, pain. So once we knew that that's what we were dealing with, we literally just followed the instructions. So if you do ever happen to make a run down there, and we have had a few, there was a shark bite there. You don't ever think about making a shark bite in northern Kentucky, but that has in fact happened. So it does happen occasionally where there will be a call for service down there, and it's normally a pretty interesting thing because of what the creatures are that they house.
Before I forget, I will screen share. I'll do all the things this time. All the things. Share. I'll turn my video off.
And this is going to be the poison patient, treatment modalities and rationales that go along with that. The objectives that were sent out: briefly review medications and other items found in the poison patient. We're going to look at pharmacodynamics and pharmacokinetics and poisoning. That is what the body does to the drug and what the drug does to the body. And then review antidotes found in EMS or emergency medicine. We'll talk some of the risk benefit of administering activated charcoal, which most of you guys are probably not carrying anymore. It has been taken off of the list from K-beams. And discuss resource for managing an overdose patient, poison control, maybe the hazmat team, toxicology,
I will mention toxicologists are kind of hard to come by. So the best chance for you being able to get in touch with the toxicologist is going to be at a level 1 center. So for the area here in Northern Kentucky, I would contact University Hospital. They do have some board certified toxicologists on staff. But other than that, it's going to be pretty hit or miss as to whether or not you're going to find somebody that's certified in toxicology. It's kind of an add-on specialty after medical school and residency, et cetera. All right, so we're going to start off here with cyanide poisoning and cyanokits. I'm going to be talking to you about it. The presentation was created by Schoberg, as I already mentioned, so to give him some credit for it. So the purpose here, toxic gases continue to be produced from a smoldering fire, and this goes without being said. So part of this is going to be like the first part of the lecture about us, right? We need to make sure that we are providing protection for not only the public, but for ourselves as well. So as we respond to situations where synthetics are burning and we know we're producing cyanide gas and carbon monoxide and those types of things, we need to make sure that we are protecting ourselves as best we can as well. Even if the air appears to be smoke-free, toxic or products of combustion can still exist in dangerous concentrations. So again, make sure that we have good air monitoring and you're utilizing the equipment that you have prior to doffing SCBAs and getting out of the equipment. And I understand that that can be very difficult to do. We're always quick to try to take your SCBA off and not necessarily have any type of respiratory protection, especially on a very hot day. But the reality is if we can protect ourselves from the respiratory component, hopefully it will benefit us long into the future. So air monitoring devices should be deployed and firefighters should continue to wear their PPE and SCBA until overhaul is complete. This is probably written in most policy or at least guidelines. In the reality, as I've already mentioned, it probably does not occur that way. And I'm not throwing stones. I have been guilty of that as well. We just need to be aware and probably better about not violating that particular policy. So what is the hazardous atmosphere? So flammables in excess of 10% of their lower explosive limit, or LEL. If you are a hazmat person, then this is going to speak to your language. If you're not a hazmat person, then just kind of bear with me for the next few minutes here. But 10% of their lower explosive limit is flammables, and that's going to be a hazardous atmosphere. So oxygen, it should be around 20.9%, or most people would say 21. If we have oxygen concentrations less than 19.5 or greater than 23.5, it impacts ability to carry the oxygen. So hazardous atmospheres, obviously, if it's less than 19.5, there's not enough oxygen there. So we're not going to be able to pick it up and utilize that through normal products of respiration and ventilation. And then any other condition that is considered an IDLH, and that's immediately dangerous to life and health. So you'll hear that referred to in like a hazmat perspective or whatever, an IDLH environment, and that's just an environment that could be immediately dangerous to your life or to your health. So what's in the air? So we talk about air monitoring, and we need to pick up on whether or not we should be able to doff SCBAs, et cetera. But what is in the air? So some of the things that are airborne that we should maybe be at least familiar with or concerned with: carbon monoxide and carbon dioxide. So mono means one. So when we are looking at this from a chemical breakdown, and I'm only bringing this up because I hear it on the radio all the time, individuals will get dispatched, and that's one thing that's coming from dispatch. But probably more striking is when we have folks that return communication on a radio and say it was a CO2 activation. And if it was a CO2, that's fine, but CO2 is carbon dioxide, not carbon monoxide. So again, if you're new into it, make sure that you're using proper terminology because other people are listening to that. So carbon monoxide, carbon dioxide, formaldehyde, cyanide, and that's what we're going to kind of focus on here: nitrogen dioxide, sulfur dioxides, and then other carcinogens. So there's a lot of different things in the air that we're breathing in unbeknownst to us, because some of them don't have, a smell, some of them don't have taste, those types of things. So we're pretty unaware the environment that we're in until sometimes it's too late. So how do they get in? Obviously, a pretty elementary depiction here, but we can either breathe them in or they can be absorbed through the skin, especially on a very hot day when all of your vessels are kind of dilated out and you are perspiring. It's going to allow the those unwanted parts or byproducts to basically be able to penetrate the skin more readily. So we don't want to do that. So what do we do to protect it? Obviously, if you have the ability to kind of wipe off, I know some agencies are carrying like baby wipes and those types of things to clean skin. The other thing that we're able to do is obviously wear your full PPE, including SCBA, and then try to get the PPE off and make sure that you get cleaned up and you get a shower as soon as reasonably possible after the event. It's really the only thing that we're going to be able to do to try to protect ourselves and prevent some issues down the line. Air monitoring equipment, the tool is only as useful as the operator's skill level. So we have air monitors available to us. Sometimes they get used correctly, sometimes they don't. So I would encourage you to be familiar with the type of detectors that you are using and what the information is telling you. So instrument response time. So the operator should know how long it's going to take for the device to obtain a sample. So you can't necessarily just turn a device on and allow it to calibrate and then walk through a 2,000 square foot house and do it in 30 seconds and expect that you're going to get really good results. So make sure that you understand how long it's going to take for the pump to pull the sample in and then to give you some sort of a readout. Not knowing the information may result in false negatives. So exactly what we just talked about. You walk through the house and, you know, there's nothing in here. We didn't get anything on our monitor, but the reality is you didn't allow the machine an appropriate amount of time to do the sampling that needed to be done. And then always make sure that your machines are calibrated based on the manufacturer's recommendation. The departments that I have been a part of have kind of had one person that is responsible for that. Just so that they know it is getting done, and then everybody else just benefits from that person's added workload. So that individual comes in, they make sure that things are calibrated, they'll buy new sensors if a sensor goes bad, etc. And then the machine gets put back in service, and the rest of us are just responsible for making sure that the thing actually operates and the batteries are charged. So what's normal? To find normal, you got to know abnormal. And this goes across the board with everything. So I've kind of referenced a few times. If you're new into this, if you're getting ready to take a national registry or a school test, if you know normal, you can always work backwards and figure out the abnormal. So I can't stress this concept enough. In order to know normal, in order to know abnormal, you have to know what normal is. So in order to know normal air, we would know that it's 20.9% oxygen, 78.1% nitrogen, and then 1% other constituent parts. If you have any deviation from that, it is considered abnormal. And what happens is you may turn that device on, and we'll look at a device here in just a second, your monitoring device. You may turn that on and it's saying that it's not 20.9%, but it's 19%. Don't have the mindset of, okay, well, that's going to be close enough. 19% oxygen and 20.9% oxygen are two completely different things. And you may be in an environment that is oxygen deprived, and you are unknowingly going into that because you don't see it, you don't smell it, you can't taste it. It's just an oxygen depleted environment, and our machine is telling us that, but we're not registering that in our brain. So make sure you know normal and abnormal, and use the information that is printing out on your device. So how do we monitor the air? So here's a couple different devices. These are both MSA manufactured. These are devices that we have available to us, single gas monitors and then a multi-gas monitor. So the point here is they look pretty similar for the most part. They have a couple buttons, they have an LED screen, they have an on and an off, but they do two completely different things. So this monitor here on the left is a single gas monitor. It is only looking at hydrogen cyanide, which is HCN. So if we think that we have a cyanide type situation, this would be a good gas detector to get, and it's a single gas monitor. If you're looking at the other one, this is a multi-gas monitor, and it will have 4 different gases depending on the manufacturer and the type of machine that you get. This four gas monitor in particular is looking at four things, okay? It's looking at the lower explosive limit, and it registers at that 10%. It's got an oxygen sensor, so it's looking at your oxygen, and you can see here in the picture it's 20.8. It's looking at CO, which is carbon monoxide, and then it's looking at H2S, which is hydrogen sulfide. So sewer type gases, those types of things, if you had a confined space, you would want to know like hydrogen cyanide. So again, just be familiar. You can't turn on this hydrogen cyanide and drop it into a manhole and then send people down there. Yeah, it might tell you that you don't have hydrogen cyanide, but it doesn't tell you anything about your oxygen concentration, and it doesn't tell you anything about the hydrogen sulfide that you're actually looking for. So please be familiar with the type of equipment that you are using, and if you're not, make sure that somebody gives a little bit of a refresher on that material. All right. So let's talk about cyanide. I told you we were going to talk about cyanide specifically, and that's why we have the gas detector up here looking at hydrogen cyanide. So what is cyanide, and how do we monitor for it? So first of all, it's got a vapor density of 0.9. That tells you that it is lighter than air. So remember, a vapor density of 1 is an equivalent to air. If it's 1.1, it's going to be heavier than air, so it's going to be closer to the ground. So anything less than a 1.0 is going to be lighter than air. So if we had a concern that there was cyanide somewhere, the chances of it being on the ground are pretty low. It's probably going to be higher. So if we are checking for cyanide, we probably need to be going above the area that we are actually checking at to see if there is cyanide present. The permissible exposure limit, it's called PEL, and that's 10 parts per million of cyanide. And these are all like OSHA and like federal type standards. And this is the amount that a worker can be exposed to over an 8-hour shift. So if you are in a situation where you're doing something that has a byproduct of cyanide in an 8-hour shift, the permissible exposure limit is 10 parts per million. The IDLH, so when it becomes immediately dangerous to life and health, is 50 parts per million. The explosive range, so it has your LEL, which is your lower, and your UEL, which is your upper, is 5.6 to 40%. So it's actually got a pretty good range there. And then the alarm will go off when you hit 10% of your LEL. And that's pretty standard, depending on if you're not familiar with what I'm talking about, maybe talk to the people that do your calibration. I think it's a pretty standard setting that your LEL will activate at 10% of the explosive limit. So again, just kind of giving you a little bit of science background on what cyanide actually is. So what are we talking about when we talk about cyanide poisoning? So it is normal to have a low or a non-toxic level of cyanide in our body, and these are produced from certain foods. Ironically enough, my wife was talking to me yesterday. She's watching Ozarks for like the 4th or 5th time, and I guess she missed it on the first couple times that she had watched it, but they were talking about the cherry pits, and they produce cyanide, and she said, I'd never heard that before. And I'm like, well, sure. I said, actually, we're going to do a talk about this tomorrow. So there are a lot of things that do contain cyanide to some extent. You can see them there, the common examples: almonds, cherry, peach pits. They do have a little bit of cyanide in them. So if you were trying to test for that, you may have a little bit of cyanide within your body. But again, these are commonly found, probably not much for us to worry about, and certainly not anything that we need to be treating. Cyanide is going to be an asphyxiant toxidrome, so you're going to have the possibility of a sudden loss of consciousness. So this goes back to make sure you're using the proper monitoring, because if the monitor starts going off and we know that we have cyanide present, then you're able to hopefully escape or retreat to a safer area. If you're using a 4-gas detector, then you're going to rely on a percentage of LEL before that machine will actually activate, because it is not looking for cyanide in particular. It's looking for hydrogen sulfide. So make sure that you are being as safe as you possibly can, and you have people with you that understand the equipment that you're using. Cyanide is 35 times more toxic than carbon monoxide. And this really becomes problematic for our first responders. So we always talk about carbon monoxide that has a 200 to 300 times greater affinity to the hemoglobin than that of oxygen. But the reality is cyanide is even worse. And we know that synthetic materials are going to produce cyanide gas. So put your FCBAs on, wear them until overhaul is over or until you can verify that you do not have any of these dangerous gases present. The amounts of cyanide detected through air monitoring are dangerous and should be treated as such. So what actually happens? So it basically is going to decrease your body's ability to use oxygen. So if we were using the 4-gas detector, what you may see is that 20.9% is going to be reduced. It's going to tell you that there's like 17% or 18%. And that should be a big clue to you that there is something else in that air or in the atmosphere that is eliminating the ability for oxygen to be there, and it is replacing it with something else. And in this case, it's going to be cyanide. You have chemoreceptors that cause an increase in respiratory rate and ventilation. You should be familiar with the terminology of chemoreceptors, chemo meaning chemical. So these are located in the medulla oblongata, or the base of the brain. And it's going to cause your body to have an increase in your respiratory rate and ventilation. And that's just a compensatory mechanism for your body trying to figure out why you all of a sudden have a reduction in your oxygen carrying capability. Patients are going to become extremely air hungry with that increased respiratory rate, and then apnea will later progress. And the reality is they don't know why it's happening. They just know that they don't feel like they can breathe and they can't. And it's simply because the oxygen has been displaced in the atmosphere. Cardiovascular system, the heart is going to consume the most of any of the other organs in the body as compared to weight. So on an on per gram basis, the heart is going to be the biggest hit. As the heart detects a decreased oxygen supply, the heart's going to do what it does, and that's going to be increase the heart rate, which is going to lead to even more myocardial oxygen consumption and demand, and then eventually an infarction, because we don't have the oxygen carrying capabilities at this point to benefit us. As hypoxia and shock progress, then you're going to end up going into bradycardia, and then other lethal dysrhythmias are going to be seen. It's going to look like the patient is reperfusing potentially, so they're going to have all kinds of funky ventricular ectopy, bradycardia, obviously, and then asystole and death. So what do we do for a suspected or unknown exposure? And what we have the ability to do now is the cyano kit. Some of you may carry the cyano kit, some of you may not. That's fine. It is costly for agencies to have this. It does have a relatively long shelf life of about 3 years. So if you buy it, and you break it up over a 3-year period, it's roughly $300 a dose. If you're looking at a one-time hit, it's about $1,000 a dose. So it depends on how you have to sell it to your administration. If you do not have it available to you, I would highly recommend that you know where you can get it at. Maybe it is your neighboring department. Maybe it is University Air Care. They have it available to them. So if your agency doesn't have hydroxycobalamin or cyano kit available, at least know your resources on where you're going to be able to get cyano kit from in the event that not only the public, but certainly one of our first responders is overcome with potential for cyanide poisoning. So I'm going to take a little bit of time here and kind of talk about cyano kit, and then what the previous medications were and why cyano kit is actually such a good benefit to have at this point. So it is administered as an antidote, and the primary goal there is to remove the cyanide so that aerobic metabolism can resume. We're not talking about from the atmosphere. Hopefully the person's already out of the atmosphere at this point. We're talking about internally in the patient's system. We want the cyano kit or the hydroxycobalamin to bind to the cyanide so that it can basically be peed out or eliminated through urine. If that happens, now we have the ability to carry oxygen on those hemoglobin once again. So the medication that we're talking about here is hydroxycobalamin. It's 5 grams, and that is capable of binding cyanide to become cyanocobalamin, which is basically vitamin B12. If you end up, if any of you are drinking like a Monster or any type of energy drink, if you look at the back of that, My guess is that you'll end up finding cyanocobalamin as one of the ingredients in the drink that you are consuming as you sit there. So cyanocobalamin is one of the things that you will find, and it is vitamin B12. That is subsequently eliminated in the urine. The cyanide poisoning has been eliminated, and hopefully the patient has, a long, healthy life. What we used to do years ago, and for those of you that went through like the Tox Medic or were part of the hazmat Tox Medic team, we carried these medications. And this was a 3-drug combination made up of amyl nitrite, sodium nitrite, and sodium thiosulfate. These are considered older antidotes, and here's the problem with this. If the person truly had cyanide poisoning and they were administered this 3-drug combination, then you saved their life. It was going to bind to the cyanide. It would eliminate the cyanide. They would have the ability to carry oxygen, and then moving forward, hopefully they would do fine. In the event that the person was not cyanide poisoned, what you had effectively done was block the hemoglobin from being able to pick up oxygen. So probably not a good thing to do. And the problem in the field or in the pre-hospital setting is it can be hard for us to determine if the person has cyanide poisoning or not. So if I back up one slide, enter cyanokit or the hydroxycobalamin, we can give this medication now to really anybody, and it's not going to have benign or untoward side effects if they are not cyanide poisoned. The reality is they have just gotten their annual dose of vitamin B12. It'll be eliminated over time in the urine, and there's not going to be any type of side effect or untoward effect from the administration of the medication. So what I'm trying to tell you, if you think that you have somebody on your scene, certainly a firefighter, a mask came off, something like that, administer the cyanokit. It's not going to cause them any harm. They're going to get a big heaping dose of vitamin B12 all at once, but it's not going to cause them to have inability to carry oxygen on the hemoglobin. If you are still using this older system and this older antidote, then it can certainly cause problems for you if the person is not in fact cyanide poisoned. So just something to think about if you have these medications available, which is why we still have them available. We just don't administer them. We would go with hydroxycobalamin, but we have these medications because they can be useful in other situations for antidotes. Communication with EMS, basically we're going to have to coordinate and communicate with the medical personnel, and that should be an ongoing thing. Ensure that the ambulance is available and dedicated as an ambulance on the fire scene. I think most of us are pretty good about doing that. Even when we would respond, and still in the department that I'm at now, if we're responding mutual aid for any type of fire, we always send an ambulance too. Has nothing to do with trust of the other agency or your mutual aid. It's just simply so that we know our people are going to be protected in the event that something goes sideways and we have to transport them. Knowing the agencies around your department that carry cyanokits would be very beneficial. When I was working at Newport, they did not have it. I'm not sure if they do now, but Covington did. It was in CAR 2. Made a couple calls actually where it was utilized out of CAR 2. AirCare has it available, and now I'm in Hebron at this point, and we do carry cyanokits. So if you guys need it as a resource, feel free to request us, and we would be happy to bring it to you. But if you're not close to one of those agencies, then know your next door neighbor and whether or not they have it and who you would call for in the event that you need it. So as I already mentioned, they can be kind of cost prohibitive, upwards of $1,000 a dose. Therefore, a lot of agencies don't carry them, but it does have a 3-year shelf life. So you do get a little bit of time out of it. So decontamination, if you have somebody that you think has been poisoned, cyanide poisoned, remove the patient from the environment. Make sure that they're on 100% oxygen with a non-rebreather. Suction the airway as needed and move them to intubation if you need to do that. But as the mucosal edema worsens, obviously the airway is going to be even more difficult to obtain. From a cyanide poisoning perspective, that may or may not occur, but just be aware that the earlier you can intubate somebody and put them on 100% oxygen in one of these types of poisonings, the better off you're going to be. And then skin for patients only exposed to gas. Basically, what you're going to do is remove the patient from the source and then remove any other clothing or trapped or absorbed vapors. There's not going to be a whole lot that you're able to do as far as decontamination of the skin from a gas. All right, let's look at the CyanoKit setup. So the only reason I left this in here, put this in here, is just so that you kind of get an idea. Make sure you know where they are kept. And if you have multiple units, that you keep them in the same spot, because in the unfortunate circumstance that you have a firefighter down that you're trying to get this to, it is going to be a hectic situation, and you need to know where they're at. So CyanoKits in our agency are kept in identical places on the ambulance. And inside the case, you have angiocash, you have a quick reference guide, the CyanoKit itself, a 500cc saline bag, and then large syringe and IV start packs so that you can administer, you can initiate an IV, and then you have your entire setup here to get the hydroxycobalamin or the CyanoKit administered to your patient. So the CyanoKit is branded. It is a kit that contains 5 grams of hydroxycobalamin for IV administration. It can be cost prohibitive, but it does have a 3-year shelf life, so it does offer an extended lifetime, which can be seen as a pro over the cost, especially if you can sell it that it's only $300 a year. Will turn the patient's skin and secretions red, and that can last up to a couple of weeks. So if you give that to a patient and they regain consciousness, etc., make sure that you tell them, or obviously the hospital probably at that point tells them, that it's a side effect of the medication that has been administered to them, and it is a completely normal finding. So when do we give this? So if a patient was exposed to fire, smoke in a confined space and cyanide poisoning is suspected or known, then we would administer this. What I would like to share with you is make sure that you give this through a dedicated IV line. You don't want to mix this with other medications. So if you're going to put the line in, basically it's going to be dedicated for your CyanoKit administration. PEDS dosing, we'll look at this just briefly. I don't expect you to remember this. Certainly you can use other resources to determine, but the dosing here is 70 mg per kg and to a maximum of 5 grams. So if you just did the math, we take 5 grams, you're going to put this in 200. That gives you 1 gram per 40 or 1,000 milligrams per 40, which breaks down to a concentration of 25 milligrams per ml. In a kid, the point is you should be administering about 3 cc's per kilo for pediatric dosing. So again, I don't expect you to really remember that, but the time to figure this formula out is probably not when you have a kid that has been cyanide poisoned and is on their way to cardiac arrest. So if you want to jot this down or put it in notes, or at least have a quick reference in the event that you have to give this to a pediatric patient, it is approved for peds. It should be about 3 cc's per kilo of the final concentration that you would be administering. All right, so diluent does not come with the kit. 200 cc's of normal saline must be added to the glass vial. So if you remember back in our kit, they carry a 500 cc bag. In order for your concentration to be right, you need to add 200 cc's of normal saline that you have to add to that glass vial. So what you're going to end up doing is there's an autofill injector port basically. And we'll talk about this here in just a second, but you're going to end up filling that glass bottle, which is going to end up giving you your final concentration, and then you're going to administer this over 15 minutes of time. So the IV tubing, there's 3 different types of tubing: a gravity or a non-vented, a filtered, and then a vented type tubing. So the tubing that is going to come in your CyanoKit is we'll look at here in just a second in literally the next slide. So how you're going to assemble this, you're going to take 200 cc's of normal saline. You're going to put that into the glass vial via the transfer spike. So there's already a transfer spike that is available. You're going to stick that into the 200 cc's or you're going to administer 200 cc's of normal saline into the glass vial, and there is a fill line on there. There's a line on the glass vial to fill for the 200 cc's. Once you get to that 200 cc's, you need to stop. Otherwise, you're going to have it too dilute. for administration. We want our concentration to be the same. We're going to rock the vial back and forth for about 60 seconds, but we don't want to shake it vigorously. Just make sure that you're kind of turning it back and forth so that the medication can mix with your normal saline. The next step, you're going to take the supplied vented tubing, okay, and you're going to connect that to the existing IV site and line, and then you're going to infuse that over 15 minutes. So you can see here's my vented tubing. I'm going to attach that to the hydroxycobalamin that we've already added our saline to. And then this part of the line is obviously going to go down and insert into the patient's angiocast so that you can administer it over the next 15 minutes. Final thought. Heart attack and cardiac arrest are the leading cause of line of duty deaths in firefighters, with a lot of these occurring on the fire ground. So really the question is this: is it from a cardiovascular disease, or could it have been from a cyanide type poisoning? We don't know. You know, structure fires are violent situations. Did the mask come off? Did they not mask up quick enough? Was there one of those types of situations? So the point and the thought is this: especially in firefighters, if they are downed at a fire scene, administer hydroxycobalamin. Give them the medication, transport to an appropriate facility, making sure that they know that you're coming in with a firefighter and that they have been administered hydroxycobalamin, in hopes that maybe we can reverse the cyanide if that's what it is. If it is in fact a cardiovascular type situation, then maybe we're not going to be as fortunate in those situations, but we're not going to know until we do. So the only way that we can kind of rule that out is to administer the hydroxycobalamin. So just kind of final thought for you guys. Again, not something that we give a ton of. I have never personally administered the cyanokit. As I told you, though, I have been on the scenes where they have been administered a handful of times. So I've been witness to it. I've just never done it myself. The thing is, think through these things now while you're sitting in a classroom, in the event that you have to do it later today or tomorrow, or unfortunately, at least you're going to have an idea of what your plan is going to be, so that you're not kind of fumbling at the time that the patient needs the medication administered to them. All right, so there's some bibliographies there.